Thank you, Mr. Chair, and thank you to the organizing committee for inviting me to this symposium. So my task is to discuss about gestational diabetes, which now the new terminology is hyperglycemia in pregnancy, or HIP, which I shall allude to. But from a general physician's point of view, I think this subject is of great importance beyond pregnancy because of the linkage of the chronic problem of non-communicable disease, which is in epidemic form, which has got to link with the maternal health programs of our country and most countries, because it has a bearing. As you can see, this cartoon on the right shows that the fetal programming that occurs in the maternal womb is what would determine the future generation's risk of chronic non-communicable disease, which could be an overweight baby or even an underweight. So I would not choose any one of these babies, either of these babies, as my own, if and when. So, ladies and gentlemen, the difference of hyperglycemia in pregnancy is not just frank diabetes, but any degree of carbohydrate intolerance, first recognized during pregnancy and even if it persists after pregnancy. And overall, the implications for pregnancy are many, but from a physician's perspective, it is important to realize that a woman who has had gestational diabetes before has a very high risk of recurrence in subsequent pregnancies, as well as her own risk of future type 2 diabetes can be as high as 60% over just a very short period of time. And our experience is that women who have developed gestational diabetes develop type 2 diabetes even as an early age of mid-30s. So this kind of gives you the overall picture of the new terminology of hyperglycemia, where on the left side it is pre-existing diabetes, or what we call DIP, which could be type 1 or type 2, as well, while gestational diabetes is where pregnancy itself, the hormonal changes, would uncover the risk for future diabetes, which might occur in a pre-existing diabetic who is being seen for the first time and being tested in her life because she's pregnant, or the true gestational diabetes, which reverts back to normal soon after the placenta comes out. Because the placenta is the offending organ by producing large amounts of anti-insulin hormones. So what is the magnitude of this problem in Sri Lanka? Community-based prevalence has shown an exponential rise over the past 30 years. And I would vouch for the latter two on the right-hand side, which were properly conducted, community-based, randomly selected sampling. And you could see that this is purely gestational diabetes, excluding those with pre-existing diabetes that we would find in 1 in 7 women or so. And the fact that 10% of these remain to be diabetic in early postpartum period. So we could appreciate that these are women that we physicians need to address even when they are not pregnant. We have a very well-structured maternal and child health program, which is essentially driven by the field worker of a trained midwife, but we have approximately 400,000 pregnancies per year and about 360,000 that carry to term. And this would mean that we have to handle about 40 to 50,000 pregnancies affected by hypoglycemia. So I thought I would start with a case scenario of a 36-year-old woman who is in her 3rd pregnancy with 1 living child, who is 8 weeks pregnant. And these are her fasting and 2-hour postprandial blood glucose values in milligrams per deciliter. And she denies she has diabetes. Now, it is extremely important, even from a physician's point of view, to look at the previous obstetric histories. And what one would notice that 15 years ago, she has delivered a child by cesarean section, and the birth weight is 3.9. Now, any birth weight over 3.5, we need to be alert to the fact that she has developed a macrosomic baby. She has miscarried at 14 weeks, 9 years later. She has been struggling to get pregnant with irregular periods, and her booking BMI is 35, and she's hypertensive. So she's most likely to have had something like polycystic ovary syndrome, which has been kind of managed or suboptimally managed, but she does not know that she has diabetes when she's a clear person at risk. On direct questioning, we found that for 4 years she has worked as a housemaid in the Middle East, which is often a risk factor for gaining weight and developing diabetes, and that she has been actually investigated for subfertility, where someone had actually done a glucose tolerance test, a 75-gram glucose tolerance test, done an HbA1c. She was diabetic, she was asymptomatic, probably lack of communication or understanding, and there was no intervention of metabolic control. And in fact, from an ethical point of view, as to how isn't this a missed opportunities to provide optimal preconception care. As you know, we heard about teratogenicity. High blood glucose in the mother is also teratogenic and causes multiple fetal anomalies, and also would affect the mother's well-being and outcomes, as well as the long-term effects. So, in fact, we need to support the fact that if there is infertility, we need to give holistic preconception care. It should include a 75-gram oral glucose tolerance test, particularly in the setting of PCOS, which has been an international recommendation where data from Sri Lanka was also taken into account. So what about hyperglycemia in pregnancy? We need to address the pathophysiology, as our chairperson said, and also look at what targets we need to achieve through multidisciplinary inputs, as well as to adopt a pragmatic life cycle approach, because these women need follow-up postpartum and into pregnancy, which is often where they get missed out. So this cartoon kind of puts it into summary that a normal pregnancy is in fact a state of maternal starvation, and that on the left side is of a fasting state, and that on the right is of a fed state. And you could see that these blood glucose values are around 80 milligrams per deciliter lower than a non-pregnant person's, even in a fasting, and even in a fed state it's 120, and in fact 90 to 120 are targets in a pregnant woman with hypoglycemia who we would want to achieve, because these are the normal values. And there is facilitated diffusion of maternal glucose to the fetus, whether she's fed or fasting, and while the growing placenta elaborates more and more anti-insulin hormones, which gets back into the mother's circulation and worsen her risk of developing diabetes. So it is a dynamic situation, very different to the standard diabetic patient, almost like a patient who's had a renal transplant is on many diabetogenic drugs. So what actually happens to the fetus? This is the famous Peterson's hypothesis, which explains it so well. The placenta does not transfer insulin, but transfers glucose, so there is fetal hypoglycemia, and thereby a response of fetal hyperinsulinemia, and the baby actually does not get diabetes, but runs a risk in the long term. So in the mother, early pregnancy actually favors lipogenesis, and glucose tolerance can even become normal. But in late pregnancy, particularly in the obese older women, they develop very high, particularly hepatic insulin resistance, which can lead to hyperglycemia. So high glucose, high insulin in the fetus causes macrosomia, which we address, just as much as there can be polyhydramnios and also sudden fetal death. And the sudden fetal death is due to metabolic fluctuations, potassium changes, ketosis, and many other unexplained causes. There can be mechanical problems in delivery, and particularly shoulder dystocia is considered as something that must be prevented, while neonatal hypoglycemia is something that now that the neonatologists are high on the alert for when managing such babies. So just to go back into the ill effects on the fetus, one could see that on the left-hand cartoon that as the fetus develops, the growth, it is liable to accelerated growth due to poor diabetic control in the mother, while In the early phase, just like in teratogenicity, if the fetal development, if we don't catch them early enough, we would miss. Those are also missed opportunities where the fetus might be at risk, particularly from multiple congenital anomalies, but just as much as those that escape congenital anomalies are at higher risk of cardiomyopathy, which it is like a hypertrophic obstructive cardiomyopathy, which regresses in late infancy, while neonatal hypoglycemia, hypocalcemia, and jaundice and respiratory distress syndrome can occur to these babies. The mothers are at particular risk of preeclampsia, and this is very interesting because the placenta is such a vascular organ. It undergoes several changes, just like atherosclerosis through lipotoxicity, and changes in the prostaglandin mechanism, and therefore they have to be really looked after because there is a very close link between uncontrolled hypoglycemia of pregnancy and preeclampsia. So this was a highly debated point as to whether impaired glucose tolerance in pregnancy can have adverse effects on the fetus. And this study, which was reported exactly 10 years ago, having been carried out for 10 years previously in 25 countries, clearly showed that there was a continuum risk for adverse perinatal outcomes, be it high birth weight, be it neonatal hypoglycemia, shoulder dystocia, or high C-peptide levels in the cord. So in summary, ladies and gentlemen, in terms of the complications of hypoglycemia, pre-existing diabetics can miscarry, congenital malformations, they can be stillborn or neonatal death, while those with gestational, which is later on, are more perinatal problems, while fetal macrosomia, birth trauma, induction of labor needing or cesarean section, and neonatal problems, and long-term obesity and diabetes in the offspring is common to both varieties, early and late pregnancy. So what about the pre-gestational variety, like what I depicted in our case scenario? Well, they confer graver risks, and therefore the physician plays a role because they should have been ideally managed preconception. Just as much as screening and diagnosis has led to a lot of confusion, not only in Sri Lanka, but in many parts of the world due to different recommendations coming out. But the more pragmatic, particularly the Indians who have a very not as organized MCH system, they really adopt the non-fasting 75-gram glucose challenge test. So some kind of glucose loading has to be given is their argument, and catch the woman when she comes and check it out then and there. While WHO wanted a fasting blood glucose and a 2-hour value, which is still being retained through the HARPO criteria, but also I will allude to that later, which is really for gestational diabetes and not for early pregnancy detection. So our principle in Sri Lanka is that the risk factor-based approach is not appropriate because we have such a high prevalence, and therefore universal screening is being adopted, and I'm very grateful to the ministry for having taken this on as a priority. Simply because our structure shows that more than 95% of women come for antenatal booking before 8 weeks of pregnancy, which is a very rare privilege. And the prevalence of first trimester hypoglycemia is pretty high. Our latest study showed as much as 3% were detected in the field, and while our tertiary clinic data shows that about 24% of our sample have had previously undetected diabetes in early pregnancy. So the majority of the women would be unaware, and that is why we need to adopt this screening principle. So as physicians, you are very likely to be referred such patients, and therefore you need to be on the alert as to how to interpret these results. Now, the other aspect is that you need to screen for end organ damage of diabetes, as well as if they've been on ACE inhibitors or statins, to discontinue, to up the folate intake, as well as to add on aspirin on the premise that you can try and prevent fetal growth retardation and preeclampsia. So the one-stage glucose challenge test, the cutoff is 140, which is done in the first trimester, while the later one is where the HARPO criteria adopted, where any one of these three abnormal values exceeding fasting 92, 1 hour 180, 2 hour 153 would show that it would be most likely that we have to adopt the principle that it is HIP. And one aspect is that if this was using the odds ratio of 1.75 that the Harper group really took to this cutoff, while if you had an odds ratio of developing HIP using 1.5, then the 2 hour cutoff remains at 140, which would have been far less confusing. So the national guidelines are up there. It's available on the website. And the fundamental issue is fasting blood sugar is not recommended, HbA1c is not recommended, and random urine sampling nor 50-gram glucose challenge is not recommended, as we need to have a standardized approach. So how do we manage? As I mentioned before, we have to, ideally, we play a role in discussing preconception care and also long-term postpartum care as physicians. And we need to look at it holistically as well as address the unfavorable drugs and the favorable drugs. Insulin is a drug of choice in most instances, and they require frequent titration. And overall, in our clinic data, about 30% of our sample that who have actually required insulin. No doubt, the type 1 diabetics, because of the liability of hypoglycemia in early pregnancy, you might have to titrate the insulins down in early pregnancy, particularly combined with nausea and vomiting. But as pregnancy progresses, every 2 weeks you need to review your patient and also be on the watch out for ketoacidosis. While the type 2 diabetics, we need to also appreciate gestational weight gain, because if they have started obese and the midwife actually calculates the first trimester BMI, we can actually then predict as to what should be her ideal weight gain. Insulin increases weight gain while metformin kind of controls it, and therefore we can be fairly liberal about the use of metformin, but up right there comes lifestyle management, and that is where our nursing educators are of extreme importance. In terms of insulin, the first line therapy, as I said, well, we have to stop glargine and glucilin and degradac, which are category C, while the other forms of insulin available in the market are quite in order. While metformin, like in this patient that I depicted with a high BMI and a PCOS phenotype, it is a specialist recommendation of giving metformin. So, dietary advice is now more or less standard, and they are well supported by the educator nurses of small frequent meals. There is individualized counseling and a basic plan, but basically we need to restrict calories for the obese and encourage good protein intake, and about 50% of the dietary intake to be complex carbohydrates. So it has to be with much discussion and reviews, and which we have in group therapies as well as in individualized discussions between nurses and the patient. The specific targets are that to avoid sweetened drinks and concentrates, because there are a lot of social bearing on this of encouraging them to drink flavored milk, particularly, that are considered very healthy for the fetus, which has to be dispelled. And therefore, a lot of myths and misconceptions, and also the fact that you have to actually tell them small frequent meals, interval snacks, and give them the quantities. Otherwise, if you say fruits, they might even eat a comb of banana. So we need to also be aware that throughout pregnancy, throughout the day, their pre- and postprandial levels should be targeted for both types to be the same cutoffs of less than 120, and particularly the postprandial normoglycemia. So this brings on self-monitoring of blood glucose, which is not available free of charge, and therefore we have to encourage them to buy their own glucometer or share their own glucometer, and also how to interpret it and report to us, maintaining a logbook. So overall, the targets, as I mentioned, are some obstetricians prefer the 1 hour post meal, which is based on Western data, but our usual experience of using the 2 hour post meal has been good outcomes of pregnancy. And what we encourage is to review in every third day at least 2 or 3 values, and therefore over a week we get an overall picture. The insulin regimes, be it multi-dose insulin, is quite in order as to whether it should be basal bolus or premix twice daily. There is not much of a difference in the outcomes of our local data, but it's extremely important to avoid night hypos. So we encourage them to do a 7-point blood sugar series, where at bedtime, late in the night, to do a blood sugar, where most often we have to prevail upon the husbands to help them. Well, what about sulfonylureas? We do not encourage the use of sulfonylureas, but there are some parts of the world where they do use it. There is some transfer, but well, that would be better than having no control of maternal blood glucose in the absence of the facility of insulin. Metformin is far safer, and there is a lower hypoglycemia risk, and also there is the women themselves prefer it, and the weight gain is well contained. So the famous MIG study was also reported 10 years ago from Australia and New Zealand, and there they used the starting dose of 500 milligrams once daily. We usually start it at night, and you can increase right up to even 3 times a day, although we often use it twice a day, and we might add on insulin in between. So the overall outcomes of long-term outcomes on the fetuses has been very encouraging from the Janet Trovan group. Well, these are the kind of myths and misconceptions. The mothers-in-law loom, and they say to take on more certain stuff, as well as the husbands also try to, there is danger that these women might get sidelined. So in summary, ladies and gentlemen, it is overall combined effort, and monitoring is very important, and regular review of these women, and also self-monitoring to be encouraged through multidisciplinary care. So I just want to re-emphasize that early recognition, preemptive action is extremely important. And this was the Colombo Declaration signed 2 years ago. Our chairperson played a major role in this, but so we are proud that Sri Lanka was one of the leaders in highlighting the importance of hypoglycemia in pregnancy. Thank you very much.